So just an overview. So this is a talk about critical limb ischemia. I'm sure as a podiatrist, you deal with a lot of patients with ulcer, with Dr. Treppel and his team taking great care of it. So this is one of his patients that I saw in clinic, 82-year-old gentleman, all the risk factors in the world, CAD, low EF, diabetic, hypertensive, chronic kidney disease, had this second toe non-healing ulcer more than 3 months. It gets better, it gets worse, it gets better, it gets worse, of course managed by a star physician. But eventually he gave up and he's like, you know what, if you still need your job, better fix this, otherwise you're done. So eventually I see the patient, physical examination as expected, Doppler pulses, ulcer, second toe, minimal granulation tissue, some tenderness and palpation, but no gangrenous changes yet. So hopefully we'll try to save the toe. Resting ABIs were horrible as expected, and so was the Doppler ultrasound. So comes in for a peripheral angio. The issue was that the patient already had an attempt on his intervention of his leg. So we were debating how to work it out and how to define the anatomy. So we get into the cath lab because it's a right toe ulcer. Usually we get left-sided access because we go up and over and try to do everything contralaterally up and over. So this is your left groin axis. I'm sure you guys know the common femoral. Let's see if it comes up. Common femoral, the superficial femoral on the left is not bad. Some lesion here and a good, almost like a 3-vessel runoff on the left side. So the left side is not that bad. We take the iliac angiogram. That's your abdominal aorta, looks fine. You have your left common iliac, left external iliac, beautiful. I mean, no significant disease or real bad calcification. And this is your short from your right side. Some profundus disease, SFA disease, you keep going down. And if you stop right here, I'm gonna play it, but watch out for this area. There is nothing right there. It's a complete total occlusion of the right popliteal artery. There is some blood flow going down in the anterior tibial. You see the patient was moving a little bit, so I had to pan. It was a little bit hard. Again, just for a rerun. This stops right here. These are all collaterals. I'm going to show you a better picture. Hopefully, these are all collaterals coming down and then reconstituting. So the idea is the patient already has one attempt done. It's an old patient. Normally, if it's a younger patient with minimal risk factors, you would always want to give a multi-specialty approach. So always give a patient an option. Listen, you have this problem at the popliteal junction. It's very hard to fix. We can do it endovascularly, but if you fail, then surgery is always an option to look at. So being upfront, giving patient all the options is, I think, one of the major ideas of treating a person as a whole, not about the disease, but as a person as a whole. So, but because of the age and the multiple risk factors the patient had, surgery was not really kind of where I was leaning, and even the patient was leaning, and even so I was a vascular surgeon. So the plan was what? Either we do a surgical bypass, get over it, and hopefully call it a day, do an endovascular approach, or just do a medical management. But remember, the patient has an ulcer, so it is truly a critical limb ischemia. It's not claudication. We don't want the patient to run a marathon. We just want good blood flow down to the feet to help the ulcer healing and hopefully patient do well and not go down the path of gangrene. So, of course, we come in, we try to be the heroes as we want to be. So this is the picture. So if you look at it, we take the picture again from top. You see there is a superficial femoral coming, but this whole area is missing. These are all the collaterals, the geniculate collaterals, which supply all the way down to the AT. So what we try to do is, since he had already a failed attempt from the top in the SFA, we'll try to go pedal access. Now, somebody could argue saying the patient has an ulcer. Why would you want to stick an artery that might be supplying the foot itself, and you might end up worsening it or causing trauma, which is a great option. But then again, you have limited options. So the idea is to cause minimal trauma to the vessel itself, especially the vessel that's providing to the feet, and just use minimally invasive devices. So what we try to do is try to get an straight vessel up access, in this case, the anterior tibial. So we just get a very thin micropuncture, 14,000 of it's 0.0014, so 14,000 of a wire up there into the lesion, and then try to connect the dot from below to up. So the idea is, if you can't go up to down, let's try to go from down to up. So what we do is we take this microcatheter, which you can see here. We take a microcatheter and it ends right here. Normally what happens is your anterior tibial should go like this, take a turn, go up like this, and then go straight up like that. So here you can see there is a collateral coming. If you look closely, this is your collateral, which is supplying the anterior tibial. You can see some blood flow right here, but there is nothing up right there. So this whole zone going like this, going like this, going like this is gone. So we try to get the wire. So this is my wire. So here you can see from the top, let's Let's see if it plays. Oh, it's not playing. Okay. Here you can see, so this is my femoral artery. Oh, well, it's not on autoplay. Sorry about that. So this is my femoral artery right there. And, well, hopefully, yes. So this is my femoral artery right there. It stops somewhere where we really can appreciate the stump or where the end point is. And the collateral rightly comes from here. So what I'm trying to do is trying to connect this wire to this end. So we try to do that. Here I am again trying to manipulate my wire. This is the thin 14,000th of a wire which we're talking about, and I'm trying to find that channel. So I'm doing multiple views to try to see if I can connect the dot. So eventually I try to connect in. This is my femoral artery right there. This is my microcatheter, and now we are actually in the vessel. So I did connect my dots completely. So what we have to do is, because like I said, I don't want to take any devices from the feet and try to fix it up. I will still want to fix from the bigger vessel down. So what I do is I try to snare that wire. So what I'm trying to do is trying to hook the wire. So I have a hole in the feet and I have a hole in the left femoral artery. So what I'm going to do is I'm going to create a channel. So I'm going to enter from the feet and exit from the left femoral artery. So I'm going to make a long loop over 300 centimeters so that way I can start working the other way around. So this, what I'm trying to do is I connect the wire, and this you can see the wire is actually into that microcatheter up there, and now I'm connected all the way. So since I connect all the way, I can work from all the way down from top to bottom and create the channel and do all the major devices without causing any trauma to the vessel that's supplying the ulcer. So this is my ballooning. You can see the balloon is up here. Now you can see the real vessel, which I talked about, goes down, takes that turn and ends right here. And this is after balloon. So suddenly all this vessel, so you remember this collateral was coming and there was nothing below it. Now you can see the whole vessel right here connecting all the way to the dot right here. So balloon more, put a stent in, and this is what it looks. And now you can see the same vessel. This is your anterior tibial artery. He still has compromised vessel to the posterior tibial, but essentially it's the anterior tibial artery which is trying to get a straight inline flow. So remember, the idea is to try to get straight inline flow to the vessel healing, that vessel that's supplying that area of the ulcer. So the anterior tibial is going to supply your area of the second grade toe. So my idea was to improve the blood flow to help with the healing process so that you all can help and you all can do the thing that needs to be done from the ulcer point of view. So, and you can see the same vessel going down. See how brisk and everything is going down? Now you can actually see the blood vessel all the way to the feet. So yeah, everything went great. Patient goes back to the boss and his ulcer heals. So we're like all good, everything is following, time flies, but what happens is, it's like, shit happens again, but what are you gonna do? So we go back again, patient redevelops the ulcer in 6 months. So we're concerned. So the first concern obviously is whatever we did that close down again? It's usually unlikely that the etiology changed, meaning that a new lesion might have come up. The chances are probably the stent I put in did get compromised, or there are some other risk factors that the patient has which needs to be taken care of. So we go back again and we inject. And now we inject here. So my stent is gone, see? So this was my stent right here, which was connected, and I've ended up I've actually migrated my problem instead of the popliteal, I've actually migrated the problem into the distal SFA. So the thing I thought that I think I would be able to stent and help the patient ulcer actually ended up closing up again. So now the patient, that's the exact reason why there was recurrence of symptoms. So here you can see actually the lesion was right here, if you remember in the popliteal the last time, and I put a stent up. Now the lesion has actually migrated up here and the artery is blocked right at the mid to distal SFA segment. So same thing, we cross the lesion back into the AT, because there's a lot of clot associated with the instant restenosis. We actually do some aspiration techniques to suck out whatever we can from clot-wise. And there you can see actually the stent is right here, and there is a new problem that developed before the stent, and that's what caused the stent to shut down. So that's where the new problem developed, and that's why we had all the issues of the recurrence of the symptoms. So eventually we go in, we balloon as we try to. Right here you can see I'm ballooning, trying to open up the blockage. And this is what it looks after ballooning. The stent is nice and open like you see. There's good blood flow down to the AT, to the ulcer area. Looks beautiful. And here the same thing. We have good brisk blood flow going down with a straight antegrade flow, and the patient does well. So this is the final picture all the way to the feet. So the whole idea about critical limb ischemia and from a vascular intervention standpoint is to try to help work as a multi-specialty. So our goal from a vascular perspective is to improve blood flow in the healing process. Your role comes into taking care of the wound care and other associated features. So if we work together, it helps with the patient, it helps with the healing, and it decreases, because patients who have critical limb ischemia, there is a higher mortality and morbidity in the next 5 years as compared to somebody who just comes in with claudication. So it's a real problem, which you will see on a day-to-day basis. We underestimate a small 2 centimeter, 2 millimeter ulcer, and we're like, it's going to be fine. But there are repercussions to it if we don't act in time. So it's all thanks to you and PK and Dr. Trappel and the collaboration we have here that we try to do all the job and work in a group. Thank you.